Good morning, everyone. Today I'm going to talk to you on overview of inflammatory arthritis. Actually, I'm not. If you have come with the hope of learning a lot of facts and stuff, I'm really sorry to disappoint you. What I'm going to do today is just to uh, uh, remind you of what you have learned in the Faculty of Medicine and tell you how to apply what you have learned already in day-to-day practice of rheumatology. That's what I'm going to do today. So this is going to be a very basic lecture. And on top of that, why I wanted to take up this topic. Many people think that, including my esteemed colleagues, arthritis do not kill. And rheumatologists or the medical officers in the rheumatology team are just pain doctors. They are counselors. They are there to listen to patients' grievances, and they cannot do much to relieve their pain. So that's a basic understanding of many people, including the administrators, because if a staff member cannot be fully functional, I mean, due to physical means or mental means, the place where they will be posted in be the rheumatology unit, because they are just there to listen to patients. And also, many people think in public, arthritis is not urgent. Arthritis can wait. And arthritis cannot be cured. And arthritis affects only elderly. So, with this background, I wanted to talk about inflammatory arthritis to you. And this is another, there are a lot of myths about inflammatory arthritis and rheumatology. One thing is, this actually, my AI friend suggested me these things. These are the common myths among public. A negative rheumatoid factor rules out rheumatoid arthritis. NA positivity confirms lupus. All arthritis is mechanical until proven otherwise. Gout only affects big toes and overweight men. Osteoarthritis does not cause inflammation. Biologics should be the last resort. All joint pain in old adults is due to degeneration or osteoarthritis. Imaging always confirms the arthritis, and if imaging is normal, there's no arthritis. And people think that arthritis is a diagnosis, not a symptom. So I will clarify all these things during my lecture. Right. To start with, what is arthritis? It's very simple. It is actually inflammation of a joint. So you know cardinal signs of inflammation. So when joint is inflamed, these signs will be there. What is a joint? The area where two or more bones meet. So it's very simple. Inflammation in a joint is arthritis. So depending on the type of joint which is involved, there will be symptoms. Almost always, when there is arthritis, the symptoms which can be there are pain and reduced range of motion. Why the other features might not be apparent? Because the nature of clinical features will depend on the type of joint which is inflamed. You know, we have two main systems in skeleton, appendicular and axial skeleton. Each skeleton is made in such a way that it will perform its assigned duty. Appendicular skeleton is made to mobilize the body. So most of the joints in appendicular system is at periphery, and almost all of them are synovial joints. The axial skeleton is there for stability. The body should be stable while you're moving. So there will be limited movements in the axial skeleton, joints in the axial system. So you can understand, when there's limited impaired function due to inflammation, the symptom or the signs or the clinical features will be very evident when appendicular system is affected, because it has lot of wide range of motion. But in axial skeleton, since the motion is limited, sometimes you might not get the clinical features very evidently. Right. So therefore, you must remember you will not see all the signs of inflammation in inflammatory arthritis in the affected joints. Right. So how will patient come to you? Patient will not come and every patient will come and say that I have arthritis, but they will come to you with a painful joint. When you have a painful joint, does it really mean that patient has got arthritis? No, because in a joint, as you can see here, right, there are, I don't know if you can see the cursor. So there are, sorry. So you have articular structures and periarticular structures. So the two bones, articular cartilage, synovial fluid, synovium, and the joint capsule are the parts of joint. And then surrounding muscle, tendon insertion, that is an enthesis, and ligaments connecting two bones together. Insertion of that ligament to the bone is enthesis, and there will be bursa between a fibrous structure and a muscle. That those parts are periarticular structures. So when somebody has a problem or inflammation in the periarticular structures, again they will get joint pains. So when somebody comes to you with joint pain, the first and foremost thing would be to see these features are really coming from joint proper. How do you do that? Again, your history and maybe your examination. So this is how you differentiate articular pain from periarticular pain. You all must be knowing that if the joint is affected, if joint is inflamed, usually all the joint movements are painful. If we take the shoulder as an example, the patient might not be able to move the shoulder at all. But if it is due to a periarticular structure, only few selected movements are painful. Right? If we take bicipital tendinitis, it is a periarticular structure. If there is bicipital tendon inflammation, patient will be able to move the arm above the head, but patient might not be able to reach her back. So if supraspinatus tendon is affected, patient might not be able to reach above her head, but patient will be able to do all the other movements. So in that way, I mean, when you have a periarticular structure involvement, only few selected movements are painful. And pain in motion. Patient will get the pain if the joint is affected, if joint is inflamed in both active and passive movements. Whereas in periarticular involvement, usually active movements are more affected than passive movements. You do this in patient examination as well. So when patients themselves will come and tell, when there's supraspinatus tendinitis, I cannot reach above head, but what I do is I support the arm with the other hand. So that's how they present to you. So range of motion also in articular inflammation, active, passive, both movements will be affected, but in periarticular structures are inflamed, active movements will be more limited. So basically, when periarticular structures are affected, passive movements will not be affected significantly. And there are certain maneuvers you can do to confirm the periarticular inflammation. And very importantly, in local palpation on examination, when you have a tendinitis or bursitis or periarticular structure inflammation, there will be tenderness over affected structure. Usually it's away from the joint line. So you will have a precise point of tenderness in periarticular inflammation. But in arthritis, the tenderness over the joint line, and there will be crepitus as well. You don't get crepitus in periarticular involvement. So this is how you differentiate periarticular involvement from articular involvement. Now you know how to find a patient with articular involvement. Right. So if patient has articular involvement, articular pain, what are the possibilities? Since I'm going to talk to you more on inflammatory arthritis, these are the two main possibilities with regards to arthritis. It could be degenerative or it could be inflammatory. So I have taken rheumatoid arthritis as the inflammatory arthritis here. And I want to tell you something that I might be overgeneralizing certain things. I might not go to fine details and fine prints to make it easy for you to understand and for you to keep things retained in your mind. So I have taken rheumatoid arthritis here. So you can see in osteoarthritis or degeneration, everything will start with structural damage. So there will be damage to the articular cartilage, whereas in inflammatory arthritis, it is inherently inflammatory. There won't be structural damage at the beginning, but due to autoimmunity, I will explain it later, there will be inflammation originated in the synovium. And usually degenerative diseases are affected to that joint. Of course, secondary to that, you can get many other metabolic complications later, but inflammatory diseases from the beginning, they are systemic diseases. So not only your joints, other systems also can get affected. Right, this is how you differentiate degenerative arthritis from inflammatory arthritis. So degenerative pain is always mechanical, so you get the pain while using the joint. Whereas in inflammatory arthritis, pain will be there usually after a rest, that is called inflammatory pain. And in degenerative conditions, mostly used weight-bearing joints will be affected, but inflammatory arthritis, well, there will be a typical pattern of joint involvement according to the disease. And usually in degenerative conditions, pain precedes the swelling. So there will be mechanical pain for many years, then only patient will start developing swelling and tenderness. In inflammation, usually pain and swelling will start simultaneously. In degenerative conditions, usually there's no stiffness when present, because sometimes you can get some stiffness in osteoarthritis as well. It is called gelling. So your synovial fluid become very thick, and when you stay inactive for a while, they can set as a gel. So when you start to move, you might get some stiffness which will last for about few minutes, which is called gelling. In inflammatory conditions, usually early morning stiffness or inactivity stiffness, the stiffness you get after a period of inactivity is prolonged more than half an hour. In degenerative conditions, you will get reduced range of motion, but mostly secondary to bland effusions. If you take knee, if there is effusion, usually the limitation of movement, if it is not deformed, is due to mechanical obstruction of the fluid inside the joint. Whereas in inflammatory, there will be active effusions. The range of motion will be limited due to pain and tenderness and inflammation in the joint. So usually joint will be warm, very tender, and significant reduction in movement because they are active. And degenerative conditions, no systemic symptoms. Inflammatory conditions, systemic symptoms are present. So I said that I have overgeneralized. Of course, there are patients with inflammatory OA. Some patients can have, but these are the typical features you would see in each condition. Again, almost the same thing. Right. So then we know how to find a patient with inflammatory arthritis. Okay. So this is not the full diagnosis. So you know you have a patient who has joint pain and which is inflamed, which is secondary to an inflammatory arthritis, not due to a degenerative condition. That's what we all do in rheumatoid clinic every day. So we get so many patients with joint pains. So there are hidden patients with inflammatory arthritis. What we do in daily basis is to pick them up and treat. Why do we pick only inflammatory arthritis? Because it is rapidly progressive. Osteoarthritis, degenerative diseases, of course, progress, but over years. But in other future slides, I will tell you, inflammatory arthritis progress very rapidly. And they will develop deformities, which deformities are irreversible. So deforming irreversibly. When you have deformities, you are debilitated. It's debilitating inevitably. Sometimes you might see, now in rheumatoid arthritis, you will not, sometimes only your wrist is affected, significantly. Deformity will be there only wrist. So when you are young and active, you might think that this is not a significant debilitating thing. But when you treat the disease to keep you functional till the day you die. So when you are above 70 or 75, when you have to use your walking stick, walking aid, or when you need somebody's help, when you want to hold on to something to stand up, you are not able to do that because your wrist grip is weak, because your wrist cannot dorsiflex. You become dependent. You are really debilitated. You have to wait until somebody comes to you to pick you up from the chair to take you to the toilet. So we see this daily basis. Therefore, even one single joint in deformity can be really debilitating than you think. So this is, yeah. So I will just explain about these patients. These two patients actually I found in Kurunegala immediately after Corona period. So they were not able to come to the clinic. This is 18-year-old schoolboy who was coming to clinic to take treatment. He was walking to the clinic. He was off treatment just 1 year. This is how he came. And you can see his hips cannot be moved completely. And the father actually has taken him to a Ayurvedic physician. So this is how he came to us. This is a spondyloarthritis with significant peripheral involvement. Both hips were fixed in that position. The funny thing was the father is still happy because earlier he had joint symptoms everywhere. Now the Mahatya has taken everything to the hip. So that's how they brainwash, right? So a child cannot even, the boy cannot even keep the leg fully on the trolley. It is that painful, right? This is another lady, and this lady, so pathetic. She's around 45 years of age, and I have taken their consent to post these pictures in presentations. And she's unmarried. She's looked after by her 82-year-old mother, and she lives in a hilly region in Kurunegala. She could not take her to the clinic, and somehow a three-wheel driver who was very compassionate has taken her down the hill and brought to the hospital. I don't know if you can see, she has fractures everywhere. Because and we discussed with the orthopedic team, and she was not, she is a person with capacity, and she didn't want to go ahead with fixation and everything. So after that, at least her mother came to the clinic to pick her medicine. So this is what arthritis can do to you within just 1 year of time. Not only it can affect and damage your joints, there are systemic diseases. So there are a lot of extra-articular manifestations depending on the type of the disease. Your lungs, your hematological system, and your kidney, any organ can virtually get affected. And there is associated increased atherogenicity. So there's increased risk of MI stroke. In certain studies, they have found out that the increased atherogenicity is as equal as in diabetes. And there's increased risk of malignancy, increased risk of osteoporosis, and there's increased mortality. If you have inflammatory arthritis, you will die from you will die 10 years earlier in some time. Yes, sometimes 10 years earlier than you're supposed to die. Right. And so that's why we should pick them up. It can damage your joints, it can damage your other systems, and it is not uncommon as well. If it is very rare thing, of course, we might, even if we don't find it, it will not affect the population significantly. But it is not uncommon as well. 3 to 5% of the population affected by different types of inflammatory arthritis. So there's another reason for you to pick it up. But even after picking up, if we cannot do anything, again, there's no point of detecting them early. So early recognition and treatment alter the disease course. We think that inflammatory arthritis is not just a disease, but it is a disease continuum. The disease starts when you're born. You're born with the gene, and then you appear healthy, but you have the disease inside. Then there will be autoimmunity, and then there will be arthralgia. We try to pick them during this time, and then early arthritis and persistent destructive rheumatoid or inflammatory arthritis. So we try to treat them at this point without letting them going into this stage. So we try to do it even at this point also. So we can do that. That's why we have to pick them early. Then, how do you diagnose? It's basically mainly clinical. So there are a lot of advancements in rheumatology field with regards to investigations, with regards to management, but when it comes to the diagnosis, we still stick to our basics. So it's your history, examination, nothing else to diagnose inflammatory arthritis. So what are the types of inflammatory arthritis? These are the main types. Rheumatoid arthritis, very common, 1% of the population. Spondyloarthritis, there are different varieties. Altogether, again, 1% of the population. Crystal arthritis, 1 to 4% of the population. Gout or pseudo-gout. And arthritis related to autoimmune connective tissue disease, SLE, scleroderma, those patients can initially present with inflammatory arthritis, mainly SLE. Inflammatory arthritis is a presenting feature in SLE. And juvenile idiopathic arthritis and infection-related arthritis, you know the current outbreak of chikungunya arthritis, there are inflammatory arthritis associated with infections. And under spondyloarthritis, there are different varieties. The ankylosing spondylitis, we knew for many years. Now the nomenclature has slightly changed. We call it radiographic. Now, in spondyloarthritis, we have axial spondyloarthritis and peripheral spondyloarthritis. In axial spondyloarthritis, we have radiographic and non-radiographic variety. Radiographic axPI is the good old ankylosing spondylitis. And we have psoriatic arthritis. When in psoriatic arthritis also, you have different patterns. But here we talk about the spondyloarthritic pattern of psoriasis. Reactive arthritis, inflammatory bowel disease associated spondyloarthritis, and juvenile onset of spondyloarthritis. Right. So then, as I said before, the diagnosis is clinical. Now you know how to diagnose an inflamed joint. Then the aim of the first diagnostic step is to establish the main pattern, which is most representative of the patient's clinical picture. That is called pattern recognition, because each of this disease has a typical pattern of joint involvement. So you have to identify that. That is done clinically with your history and examination. Then comes to the investigation. The second step would be more detailed investigation, which is adapted to each pattern. So if somebody comes to you with joint pains, you're not going to do rheumatoid factor, ANA, HLA-B27, everything. No. You order your investigations depending on the pattern. You should always think that we have a duty towards the patient. Also, we have a duty towards our country, our country's economy. So you have to be mindful when you're ordering investigations. So then you order investigations which is adapted to each pattern and aims to differentiate between potential causes of that pattern. Okay, right. So what are the patterns? These are the typical patterns of joint involvement in rheumatoid arthritis. If you take rheumatoid arthritis, common in females, it's usually 2.5:1 like the ratio. It's usually polyarticular involvement. More than 4 joints will be affected. And there will be bilateral symmetrical joint involvement, and small joint will be affected, and mainly hand joints will be affected. So if somebody comes to you with painful, swollen hand joints, if it is a female, then you know that it is most likely to be rheumatoid arthritis. So then you investigate on that line. Spondyloarthritis. Here I say it is common in males because axial spondyloarthritis, radiographic axial spouse, ankylosing spondylitis is more common among males. So males are not that fortunate in that way. So they also get the arthritis. But when it comes to peripheral arthritis, female to male ratio is equal. But yeah, it is common. Generally, spondyloarthritis is common in males. There will be axial involvement. So in rheumatoid, you do not get axial involvement. Right? And usually in spondyloarthritis, the appendicular joint involvement will be oligoarticular. So few joints will be affected. And it is asymmetric. It's not symmetrical. And usually lower limb joints. So in rheumatoid, your hands are more affected. In spondyloarthritis, your lower limbs are more affected. And there will be also other associated musculoskeletal involvement like enthesitis. Tendon insertion, ligament insertion, bursae will be affected, and there will be dactylitis. The whole digit will be inflamed, and there is uveitis, and there will be, I'm sorry about this thing. I think something must have happened. Yeah, there will be other associated diseases. I said that spondyloarthritis is associated with psoriasis, inflammatory bowel disease. When it is reactive arthritis, you have preceding infections, mainly genitourinary infection. So you have to look for these associated other diseases as well. Arthritis associated with CTDs, again common in females. There also it is polyarticular, but here it can be migratory and symmetrical involvement. In rheumatoid arthritis, you know, it is bilateral symmetrical and usually deforming, but the arthritis associated with connective tissue diseases are usually not deforming, and there will not be on examination much synovial proliferation. So when you feel the hands of a patient with young girl who is complaining of pain in the hands, you might not feel the synovitis, but they will have enormous pain. So they have significant arthralgia compared to the amount of inflammation in their hands. That is a very significant finding to differentiate it from rheumatoid arthritis. And of course, there will be mucocutaneous involvement, which is very common in SLE during the presentation. So photosensitivity, discoid lupus, there are a lot of skin involvement and oral ulcers. You should look for this because you know that in SLE, the oral ulcers might not be painful. So you have to look for these things, and there will be involvement of the other systems. In gout is common among males, but it is not uncommon among females. But menstruating females are protected from gout if somebody but still it is possible, but common among males. And usually the presentation is monoarticular, and there is certain predilection to certain joints. Lower limbs are again more affected, ankle and first MTP, and usually it's intensely inflammatory compared to other inflammatory joints. So joint will be red, hot and angry looking. You know you are looking at gout. And the onset is abrupt. In other inflammatory arthritis, they will say that I've been having these symptoms for 2 to 3 weeks. But gout patient will come and tell you, yesterday I slept with a normal joint. Now I have this severe unbearable pain and swelling in my joint. So the maximum symptoms will be there within first 3 to 4 hours actually. So it's very abrupt onset, and usually there will be provocative factors like alcohol, tight shoes. There will be provocative factors. Right, so this is the graphical presentation of that. And this is something I want to tell you. Presence of antibodies is not equal to disease. So therefore, please don't do unnecessary investigations, because these antibodies are present in normal population in significant proportions. If you take rheumatoid factor, it is present sometimes up to 20% of the population. But rheumatoid arthritis is almost less than 1%. If you take ANA, again 15 to 20% of the population, but incidence of lupus is 1 per 2,000 of people. So it is very uncommon. Then it is really difficult to convince them of that the negativity of the false negativity of the false positivity of the test. Therefore, you must remember presence of antibodies is not equal to disease. Same time, they are autoimmune diseases. So this is what is autoimmunity. So our immune system is the army of our body. So they recognize our self-ID. When there is somebody coming from outside who is not carrying the self-ID, they attack. But what happens in autoimmune diseases, they identify they cannot identify self-ID. They start attacking self-antigens. But that's why the autoantibodies will form. But for you to say that it is autoimmune disease, this aberrant immune response directed at normal bodily constituent should lead to inflammation, cell injury, and functional disturbances. Therefore, mere presence of antibody is not equal to disease. And same time, so you have to have the pattern to diagnose disease. So are you going to wait until the pattern is completed to treat this patient? No. You will learn why you should not wait. So then we have a different entity that is called early arthritis or undifferentiated variety. Even if pattern is not there, from the joint involvement, other associated features, we can see if this patient is going to have a persistent disease or erosive inflammatory disease. It is really important to identify that. Otherwise, you're not going to treat each and every patient who is coming to you with inflammatory joint pain when it is there only for 2 to 3 weeks, because you know that all these treatments carry significant risk as well. So you should always balance this. You should not let people to have deformed joints. Same way, you should not expose these young patients to unnecessary toxic medications as well. So therefore, if you're in doubt, please refer the patient, right? This is, if you get a patient with early arthritis, this is rough way of knowing whether they are going to have persistent disease or erosive disease. I will be discussing a few case histories, then let's discuss about that there. So I said, why do we have to start early treatment? Because in one study, 70% of patients with recent onset rheumatoid arthritis develop bone erosions within the first 3 years. Importantly, within 3 months of disease onset, 25% of patients already have erosions, evidence of erosions in their x-rays. And the presence of early radiographic erosions predict the future progression of joint damage. So therefore, you can see that the joint erosions will happen earlier within first 3 months of the onset of disease. So you must start treatment to prevent those erosions. Not only that, all the systemic involvement, CVD risk, malignancy, mortality, osteoporosis, all these can be stopped by starting them on early treatment. Right. When you know the pattern, as I said, these are the investigations you do. You do not need a lot of investigations. Full blood count, inflammatory markers are very important to confirm the presence of inflammation. Liver function test, renal function test, chest x-ray. X-ray of the affected joints, very important to see if there are erosions. And ultrasound MRI when necessary. And rheumatoid factor, anti-CCP antibodies, ANA, HLA-B27, depending on the disease you're going to suspect on that patient. Treatment. Treatment should be always targeted. So you treat them with an intention. You don't just treat. So it is not only the commencement of DMARDs, you should escalate it quickly to reach your target. So what is the target? It is the complete remission, nothing else. So you want every joint to be normal. And there are instances where we cannot achieve that with existing medications, then low disease activity is fine. But again, as I said, I overgeneralize things here. There are a very minor proportion of these patients who will not completely go into remission or low disease activity even with all the modalities. We call them difficult to treat patients, but very minor proportion. And then not only starting on treatment, not only achieving the target, you should maintain that target. You should maintain the remission. Same time, you should monitor the side effects of the medication. So frequent monitoring is needed. So these are the modalities available for us. You know, we have synthetic DMARDs, conventional synthetic DMARDs, and targeted synthetic DMARDs. Methotrexate, leflunomide, sulfasalazine, hydroxychloroquine, we know this, that these medications have been there for more than, I think, more than many decades. The newer targeted synthetic DMARDs are these Janus kinase inhibitors. They are given orally. Tofacitinib is the one which is available in Sri Lanka. Then we have, when we cannot achieve our target with these medications, we usually go for biologics. There are TNF blockers, originals and biosimilars, interleukin 6 blockers, anti-CD20 blockers, rituximab, infliximab, tocilizumab, abatacept, and anakinra. IL-1 inhibitors, of course, not available in Sri Lanka. So we have, not all, but we have adequate amount of biologics, though they are not available always, but we do have options to treat our patients. Right. With these things in our mind, let's move to these cases, and I hope you will answer me. So case 1, she's a 34-year-old. All these things are real-time patients. They are not, they were truly patients who came to our clinics. 34-year-old housewife or slightly overweight lady presents with bilateral knee pain for 3 weeks duration. And this now, when you are at your practice, they come to you. And she says that she finds it difficult to do her Zumba session after dropping her son to school. So she drops her son to school and then goes to her exercise session, and she finds it difficult to do that. And she denies any constitutional symptoms. She has gastritis, no allergies. What do you think of the diagnosis? What could it be? Can it be inflammatory? Can it be degenerative? Or is it difficult to say? Yeah. One thing is she's young, 34-year-old, and both legs, both knees, and for 3 weeks. Let's move on to this. And on examination, she has swollen, tender, warm knees with reduced range of motion. She did not complain of wrist because she has a maid at home. She's not cooking. So for driving, she's driving only a short distance. So always look at the patient's background. So you should analyze your history in that context. Okay. So, but when examined, you know that one wrist was tender. ESR was just 35. Rheumatoid factor was negative because she was brought by her sister, who is a nurse in the hospital. So she has done all this investigation and she's coming to you. What do you think this could be after examination? Yeah, I will proceed. So she has bilateral knee joint involvement. They are weight-bearing joints. But remember that in rheumatoid arthritis, second most common presentation is bilateral knee joint involvement. It's the typical presentation is bilateral symmetrical hand joint involvement. Second common presentation is bilateral knee joint involvement. So on examination, you have found that her joints were swollen, warm, and usually in osteoarthritis we might not see warmth, but still osteoarthritis is also a possibility in this patient. ESR was 35, rheumatoid factor is negative. As I said before, negative rheumatoid factor will not rule out rheumatoid arthritis, but still both things are possible. CRP was 16, so it's slightly raised, so there you have some evidence of inflammation, and so possibility of inflammatory arthritis is there. Actually, what happened in this patient was, this patient was referred, this patient has gone to the GP, and GP has very correctly identified that CRP was elevated. This could be rheumatoid arthritis. This could be an inflammatory arthritis, and referred to rheumatology clinic. But unfortunately, patient was given course of steroids. So you know her sister is a nurse. So then when she came to us actually 6 months later, when all her other joints are affected, she didn't come to us because her sister was giving her steroids from the hospital. So if you're not sure of the diagnosis, if it is ambiguous, don't give them steroids because that will reduce the inflammation, and even if patient comes to us, we will not be able to see the inflammation. So if it is ambiguous, don't treat, don't give steroids, give just SOS basis NSAID and refer to rheumatology clinic. This is the second patient, 46-year-old housewife presents with painful swollen hands and feet for 2 months. She has feverishness and fatigue. She has constitutional symptoms, making her ADLs and occupational activities difficult. So housewives also have occupational activities. They are cooking, washing, cleaning. That you must remember. And her daughter's expected date of delivery is only 1 week away. So she's very worried, and she's preparing to welcome her first grandchild. So she cannot make a fist. So she will not be able to help her daughter to wash the child. So she's very worried. her wrists MCPs are swollen symmetrically. So what is the diagnosis? Here it's very evident that it's rheumatoid arthritis, age is correct, and she has constitutional symptoms. She has a bilateral hand joint involvement. And do you think even if you refer this patient to a rheumatology clinic, she will go? There's high chance that he might not go because she's waiting to welcome her first ever grandchild. So that's why I said always treat and analyze things in the given context. So it is rheumatoid arthritis, and if you describe the pattern in your notes, it's very clear that it's rheumatoid arthritis. Even if patient comes to us with no joint inflammation, it's very clear that according to the joint involvement, it's rheumatoid arthritis, unlike in previous case. So here, of course, as a GP, you can consider short course of steroids because of her context, and then you can refer the patient to rheumatology clinic or to the physician later, because here diagnosis is not a problem because patient has classical pattern of rheumatoid arthritis. So again, same thing, why early referral? When we start the disease modifying agents, within first 3 months of onset of symptoms, you can achieve drug-free remission. So about 20 to 25% of patients, we can completely stop DMARDs and achieve complete remission lifelong actually. Therefore, you should send them early. And why not steroids? It's a double-edged sword. In ambiguous cases, it might hinder the possibility of diagnosis, and patients tend to abuse. Case 3, same lady with rheumatoid arthritis comes in with fever, cough, and mild difficulty in breathing for breathing. This is 3 years after the disease. Now you diagnose the patient and you're seeing these patients regularly at your practice. And now she's coming to you with fever, cough, and mild difficulty in breathing for a couple of days. And she thinks she contracted this from her grandson, who is now going to preschool. She's on MTX 20 weekly and sulfasalazine 1 gram BD. And she has had a flare in recent past, and she was started on oral prednisolone by the rheumatology clinic about 2 weeks ago. So what do you do now? Patient is on DMARDs, patient is on steroids. She's coming to you with features suggestive of an infection. Yeah, you should continue steroids. You should not, because they are at risk of developing hypoadrenalism. Usually, they will develop this if it is given more than 3 weeks at a higher dose. But still, there is a possibility because she's having an infection. Therefore, you may continue the same dose of steroids, or sometimes you might have to increase it when if patient had been on steroids for a longer period. But in this case, you may continue steroids, but you should stop the DMARDs for about 1 week, including sulfasalazine. There are various opinion on different colleges, but basically we suggest to stop disease modifying agents because they hinder the immunity. So the simple respiratory tract infection can lead to pneumonia if you don't stop them. Fourth case, 22-year-old student, male student in Faculty of Fine Arts, comes to you with lower backache for 3 months. And he has changed his musical instrument to sitar 4 months ago from guitar. He was playing classical guitar, but he's changed his instrument, and he thinks this might be the cause for his backache. He has changed his practical session to afternoon recently as he feels better in the afternoon. So this patient comes to you. You're in a hurry, and of course, if we talk about the reality, you're not going to examine all the patients who is coming with back pain for few months in bed, will you? No. Yeah, so it's good if we all can examine, but depending on the number of patients we see, we cannot do the complete examination. But since it is for a shorter period, you might just order an X-ray lumbar spine and you prescribe NSAIDs. But you must always remember, he's a young boy, 22-year-old boy. This type of a person, 22-year-old university student, might not come to you if that pain is not really affecting his day-to-day activities, because he goes to university in Kalani and he comes to you in Kandy when he's they're at home for a holiday. So since it is very significant, so you must remember that in this particular patient. So if you have time, this is a patient that you must examine. X-ray was normal, and patient has had good response to NSAID. And because in next visit, patient comes and tell you in next month when patient came home for the holiday, he says he feels better, and he comes to you to thank you for treating him and curing his illness. What do you think? X-ray is normal. Yeah, I think even if he's asymptomatic, this is a patient that you should examine, because in spondyloarthritis or inflammatory back pain, if you go back to the history, he has changed his practical session to afternoon. So it's not a mechanical pain. So if it is a mechanical pain, if it is really due to the musical instrument, he should get the pain after the practical session. But in his case, he has more pain in the morning. That's why he has moved his practical session to afternoon. So all these small things will matter. And if you're ordering X-ray, we prefer doing X-ray SI joints over lumbosacral spine, because you diagnose radiographic spondyloarthritis by looking at the SI joints. SI joints have specific features which will be there in spondyloarthritis, but lumbosacral spine, of course, within first 3 to 4 months, you might not see. And you have to do bloods, and please examine this, not all, but important patients. You should look at the spinal movements, SI joints, and look for psoriasis that can be hidden in the natal cleft, in umbilicus, behind the ears. These areas patient also might not see. Right? Look for psoriasis if somebody is coming to you with inflammatory back pain, and look for enthesis. Case 5, 33-year-old bank officer, former rugby player, presents with left heel pain and painful right knee. So you immediately think that he's a rugby player, so he must be having osteoarthritis. Definitely he must have had ACL injury while playing rugby. So don't assume things. So heel pain was more in the morning. Knee pain was more with sitting for a longer period. On examination, there was left plantar fasciitis, and he did not have swelling at the Achilles tendon, but there was tenderness in the Achilles tendon insertion. And patellar ligament was tender, so that's why he gets pain. So he has patellar tendinitis. That's why he gets pain while his knee is flexed. And usually, tendinitis will come due to repetitive trauma, due to mechanical reasons. So he's a bank officer. He's not doing anything at all now. He comes to bank early morning, he leaves the bank around 8 o'clock, and he's not doing anything. So what is the reason for him to get these tendinitis? And this is the Achilles tendon insertion. Insertion is very important here. Insertional Achilles tendinitis, or that is enthesitis. Most of the mechanical Achilles tendinitis, then the mid-substance, non-insertional part will get affected. If somebody has got insertional part affected, that is enthesis. Therefore, please suspect possibility of peripheral spondyloarthritis. So this is not his legs actually, his feet. So you can see the dactylitis. Sometimes dactylitis is not painful, so you can miss. So it is again a feature of peripheral spondyloarthritis. And in spondyloarthritis, usually inflammatory markers might not be elevated. Only up to 30 to 50% patients will have elevated inflammatory markers. Right. Only one more case actually. Case 6, 53-year-old lady presented with red, hot, painful right ankle joint for 3 days. We get these patients from surgical wards mainly, because they come to surgical ward thinking that it is cellulitis. From OPD, they are admitted to surgical wards because skin is warm, red, and she was treated with antibiotics as the skin was red for cellulitis. That's a very correct thing to do, and because it is always common things are common, and she has had similar episode 3 months before, right? So then you just doubt whether this could be something else. And can this be septic arthritis? Of course, in any red hot swollen joint, you must think of septic arthritis, because if you don't treat septic arthritis, the joint can get damaged more than 50% of the time. Therefore, you have to suspect septic arthritis, but you should always think of gout as well. Because, as I said, it is intensely inflammatory. It can mimic cellulitis and septic arthritis. Usually in septic arthritis, the spread is usually hematogenous. Usually they have more pronounced systemic symptoms. And this kind of patients, if you suspect septic arthritis, you need to admit the patient and aspirate and assess the synovial fluid under the naked eye. So I said we have to stick to our basics. Just look at the synovial joint and please document it in the ticket notes, whether it is pus or not. Those things are very important later. And send these things to gram stain and crystals. And of course, in Kandy, we can look at the crystals under polarized microscopy, but you can still do it with the help of your pathologist, even in under light microscopy. This is what I have done in K-Goal. This is light microscopy picture, uric acid crystals. If somebody has positive gram stain or positive culture and positive uric acid crystals, you always treat for septic arthritis. You don't treat for gout. Right, the last case, 32-year-old lady presents to you with stiff, numb hands in the morning for last 3 months. And carpal tunnel release was done for one hand 2 months ago for same symptoms without any improvement. On examination, there's no synovitis. Inquiry release, when you ask more, she says she has early morning stiffness which lasts for about 2 hours. And she, of course, has positivity in her chest in both hands. What could this be? Her ESR was 40 and her rheumatoid factor is 256. So I said, this we call clinically significant arthralgia. We always try to diagnose the disease as early as possible. So before development of clinically evident synovitis, they will have no synovitis, but they're still symptomatic. So she's a female, bilateral hands are affected, and there's significant early morning stiffness, and patient has not got better with carpal tunnel release. So is the inflammation of the wrist compressing the carpal tunnel? That is a possibility, but the amount of inflammation in the synovium is not strong enough to be detected by the head, right? So, and positive rheumatoid factor, there is high possibility of having rheumatoid arthritis because it is in height eaters. So we call this clinically significant arthralgia. So you need ultrasound evaluation. So if you do the ultrasound evaluation, you can detect early synovitis by increased Doppler signals or sometimes grayscale synovitis, or it is equal to examination by rheumatologist. But no, we also miss because actually it is so not surprising, because sometimes when the patient comes, we do see the synovitis because we are trained to look at the joints. And when sometimes these patients, we had one patient actually from orthopedic ward. I'm not finding fault with anyone because we do miss, because we are trained to do certain things. So then this patient actually came to us with high ESR 140, male patient. So you don't suspect usual rheumatoid arthritis in male patient. Patient has undergone everything. CT chest, abdomen, pelvis, serum protein electrophoresis for high ESR, but patient was on wheelchair. He had significant constitutional symptoms as well. So maybe his weakness and difficulty in walking must have been attributed to the constitutional symptoms. But when from far away, we can see bilateral MTP synovitis. So when you're not trained to pick things up, you might not see, right? So that is something I wanted to say. That's why we say refer. Right. Take home, identify and refer early, drug-free remission is real, and do antibodies when there is high pretest probability of the disease. And this is actually, so though some people think that we are just pain doctors, this is what we think about ourselves. They are the Sherlock Holmes of medicine, because rheumatologists strive on solving complex multi-system mysteries, autoimmune diseases, which don't read the textbook, and neither do their patients. They treat the person, not just the lab value. Sorry about mentioning about endocrinologist here. Charles might not get offended. So we treat the patient because we do things clinically, we don't depend on the lab reports. And yeah. Right. Thank you. And this is what we all aspire to become one day. Look at this lady. She's probably in her 70s or 80s with fully functional small joints and large joints. She's weaving a coconut leaf and she appears content with intact higher functions. So we can do this to our patients if you treat these diseases early. Thank you.